I'm really honored to welcome Lindsay Andras. She's from Children's Hospital in Los Angeles and now runs that program after Dave Skaggs went on to Cedars. From everything I hear in the pediatric world, she's been doing a tremendous job down there in program building and certainly has been really increasing her role, prominence, and leadership within the Scoliosis Research Society. We've known Lindsay for many years at the meetings, and we're so happy to welcome her today to our meeting, and she's agreed to give kind of a bridging talk between adult and pediatrics, although I told her we're ready to handle any pediatric topic that you might want to discuss. So, Lindsay, thanks so much.
So when I was trying to think about things that have broad appeal, I think neuromonitoring changes are one of those things that unify peds and adults. Whether you're a fellow or an experienced surgeon, this is always an area of interest. These are my disclosures, absolutely nothing relevant. So I don't think I'm alone in loving operating, and oftentimes you feel like this when you go to work and you have a clear job to do and you're excited to do it, and then you hear something from the corner that makes you feel like this. So in this talk, we're going to talk about anticipating neuromonitoring changes, optimizing neuromonitoring signals, reviewing critical components of the neuromonitoring checklist, and then adding to your armamentarium in responding to neuromonitoring changes. So, one of the things that I think has been popularized more in the last 5 years or so is this deformity angular ratio, which I think just articulated what many of us kind of already knew, which is the curves that give you trouble are those short, sharp, angular ones. And this kind of first started to put numbers on it, and then the same group subsequently looked at 200 patients that were undergoing a VCR. And they found that if your total deformity angular ratio was greater than 25, that your chance of having a spinal cord monitoring event was around 40%. And we wondered if that was really unique to having a VCR or if that was really just had to do with that type of curve. So we looked at about 250 patients that were not having 3-column osteotomies, and we found that roughly 50 of them had neuromonitoring losses, and surprisingly, the total deformity angular ratio was really pretty similar to the numbers that were seen in the Wang paper. So if you have total DAR that's greater than 25 in those high 20s, your chance of having some excitement that day is good. The other thing that I find really helpful is the spinal cord shape classification. I'm not sure that I've seen a type 1 on my pre-op MRIs, but type 2, you still have that circular cord, even though there's not CSF passing, and type 3 is when you have a flattened, deformed cord, and then your chance of having excitement that day is around 30 times higher. One of the things that I've seen in a couple cases that for random reasons got MRIs while they were in traction is that it can change even in that. And then there are some days where you actually don't need anything to tell you that you're probably going to have some excitement from a neuromonitoring standpoint. And I think these cases, I spend as much time trying to think about when I may lose signals and how I'm going to respond and adjust to that as I do in terms of putting my implants in. They didn't hire me to do AIS, so even though we know these things can happen, we're here to straighten spines. So one of the things that I think is important to focus on, and it kind of surprises me how sometimes I talk to people that do scoliosis surgery and they don't spend a lot of time looking at the neuromonitoring before they scrub in, is I want to know what the size of the response is. And I've heard some terrible stories of things going awry because what they thought was being monitored was not being monitored. And one easy way to avoid that is by looking at your own neuromonitoring signals. And then, one of the things that we've seen in COVID is that not only is there a nursing shortage, there's a neurophysiologist shortage, and we've certainly dealt with more turnover than we've traditionally had. So I've actually had them standardize their response of all signals present and stable to baseline because that very clear terminology avoids confusion. And then we've also protocolized that once screw placement starts, getting MEPs every 8 minutes so that everybody in the team is trying to make sure that happens. I don't know if this actually is the right number for adults, but for peds, if I get a voltage that's greater than 500 on setup to get a decent MEP, I think of that as kind of a little bit of a warning sign. and whether or not they're having to do a single stim, double stim, triple stim. I recently had a case where they ran it and then there was a pause and they said, it's still there, but we had to double stim to get the same response. And I said, oh, okay, but it still looks the same? And they said, yes. And I kind of kept going. And then 15 minutes later, we lost everything. And everything came back and ended up okay, but it was a real reminder to me that if you have a change in what you need to get that, even if you still have a monitoring signal, you should be thinking about what you can do. Now, small amplitude to start with is something that we often struggle with in some of the kids that have myopathies or Charcot-Marie tooth or other conditions. And sometimes you can fix this just by repositioning the needles or widening them. But there's a couple cases every year that I run on ketamine. And the ketamine is really helpful for two reasons. One is it lets you use less of the other anesthetics, so you can typically bring your propofol down. But also it's an NMDA receptor antagonist, so it just increases your excitability, so you get your increased EP amplitude from that. Pre-positioning baselines, I do these more than I used to, so typically don't do them for standard cases, but anything with a component of instability or a diagnosis where I think they may not have great signals to start with. And then, even if they're still present after you flip, if they're different than they were before, something needs to be changed, or think about picking another day. I am a great advocate of outsourcing. I don't think really probably anybody in this room should spend very much time doing laundry or grocery shopping, but I think positioning your patients for deformity surgery is really critical, and that's one thing that I will always be there for. And even when you're there, sometimes it's still tricky. And another thing that I believe is very important is being able to see what's going on in terms of the monitors. So having them clearly visualized and having a clear goal. We oftentimes in the peds world will run them hypotensive while we do the exposure for AIS. But for kids where you're putting them in traction or you're doing any type of correction or they're just high risk in general, I don't let them get hypotensive, and we'll typically keep the maps up at 80s. And then being able to monitor the temperature too. Cold kids don't have good signals. One thing, and this is a little bit of a digression, but we are doing some research on room temperature because I have some anesthesiologists that like to cook us. It actually probably doesn't matter what your room temperature is once your bear hugger is on and your drapes are on. So I'm a huge proponent of checklists. I'll make a checklist for a Saturday of the things that I want to get done. So Gawande really spoke to me with this book. And then in 2014, when the stable spine checklist came out, we put that in every OR. And I think a couple things that are good to highlight here is this is intentionally not linear. And then subsequently last year, the high-risk spinal deformity surgery checklist came out, and I think this is really helpful as well. And I think also this kind of highlights what a lot of us did already, which is planning what your reaction is going to be if it takes place at various times in the surgery. So just a review of some of the things that are really critical in the original checklist. Getting the important experienced people in the room. That's one of my attending anesthesiologists who's also my sister, and my patient had that shirt made for her. But it is really critical to not just have fellows in there when things go awry, because even simple things can get overlooked. This can also be used as your justification for having music in the OR. So your options for getting everyone's attention are either pause the music, we've had a change in the signals, or you can have to Hulk out. So you can take this to your hospital administrator is why you need a better stereo. Okay, what to do if you lose signals. So we looked prospectively at kids, over 400 patients. It was a multi-center study, and we found that in 20%, just raising the map, generally up to 85, would get the signals back. That's 20%. That's not everybody, but that is something that's often helpful. But one of the things I've become acutely aware of is if you have to go much higher than that in order to maintain them, you probably want to change something in the OR, because maintaining that map post-operatively is oftentimes really hard. And you don't want the kid or adult to be in the ICU overnight and for whatever reason they can't maintain that map, or sometimes you have side effects from trying to maintain a map that high. Planning for a wake-up test is something I do. I tell them to start this right when we start running the checklist. This is something that's changed for me now versus 5 years ago is I just don't waste time on that. Half the time you're gonna get better signals just from the anesthetic coming off, and if not, like you can have them turn it back on, but I don't see a benefit of really delaying that unless you have a clear other etiology. And then your neurophysiologist should really be busy when this happens. So if you look over and they're not moving around actively, like they should be off the team. The other thing that's really important to remember is that my first question after we lose signals is give me the time of the last signal that we had that was at baseline. And because SSCPs take 10 minutes oftentimes to average, you are frequently not going to see that change until a little bit later. So I don't actually feel reassured when the MEPs are gone and the SSCPs are there until we're 15 or 20 minutes in. And then again, if you have an unstable spine, taking everything out is not an option. This consultation with a colleague, we made standard, and I think really there's no downside to this. Phoning a friend is helpful. At the very least, it's reassurance that everything's being done and moral support. So what do you do if you get through all this and your signals are still absent? Well, you have to assume that the cord's being compressed, and then you try to figure out why. And if it's relatively early in the case, with any underlying thoracic kyphosis, I may have been seeing these cases years ago and I didn't recognize it as much as I have, but I've had a few of these cases in the past couple years. And this was one very recently, a 13-year-old with knee dysplasia with pretty impressive kyphoscoliosis. But we really had a nice correction and traction. Family was very risk averse. And we weren't unhappy with this alignment, but went back to instrument her. And she had no neurosymptoms pre-op. Her pre and post-flip baselines were excellent. And then just as we were finishing the dissection, we had a loss in the MEPs. And we already had the maps up in the 80s because I had her in traction. So we took the traction out. No improvement, actually seemed like it was worsening. And I just thought this has to be pushing on her kyphosis. So, standardly, we're using a chest roll that's somewhat like this. And anesthesia did not love it when I did this, but we levitated the patient and changed it out for the hip pads so that she could sit lower. And we saw essentially an immediate improvement and were able to finish the case. One other thing I would note here for people that do some PEDS cases, technically I guess it would work with adults, but it's probably a little bit more limiting. If I've had them in traction for a while, I just have them scan them and make a halo vest. And then if their bone quality is really bad, then I'll leave that on for 6 or 8 weeks while the bone starts to heal in. And knock on wood, I haven't had any of those pull off acutely, so I think that can be a helpful tip. If it's not always the sagittal plane, and this was an example of a 14-year-old female with around 100 degrees of AIS. She lost all signals after her osteotomies and placement of lumbar screws. Took the screws out, none were concerning, no improvement. Phoned a friend, the Skaggs and Tolo team came, and it appeared tight on the concavity of the apex. So we removed the concave pedicles and the cord shifted over and we started seeing improvement in the signals. So she woke up with weakness on the left, but right leg almost full strength, and gradually over the course of a few weeks got full strength back. We went back to the operating room, and then we lost our MEPs on positioning. So we stopped and did a wake-up test, and she was moving the left leg a little bit, but it was clearly weaker, so we gave her a couple more weeks. And then we went back and we were essentially having the same issue. So we strategized to actually make the temporary rod a permanent rod. So this was, I thought, kind of a creative solution. It's not ideal, but in those really super sensitive cords where you breathe on them and something bad's happening, we just stabilized it and said, we're gonna let this cool off a little. You're probably gonna break this rod, and she did. And then 6 months later, we went back and revised her when she broke her rod, and it was uneventful and maybe a little less correction than you originally would have hoped for, but well balanced and always walking around. So that's the most important thing. Sometimes it's really hard to find the problem. We have now new tools like Intraop CT and MRI, but these can be a little unwieldy. D-waves can be really helpful, but at least in Southern California, we've had a little bit of a shortage in getting the probes. The thing that has actually helped me the most intraoperatively has been the intraoperative ultrasound. So this was the first case I used it on. 14-year-old male with Down syndrome who presented after months of a worsening gait. And he had this symptomatic, irreducible axial subluxation. So we went back with the intention of taking off the back of C1 and doing a fusion of occiput to C2. And just with removing the back of C1, we lost signals during the decompression, which seemed really odd. And thankfully, the neurosurgeon that I had come take a look at it thought to bring in the intraoperative ultrasound, which they use so frequently for tumors, et cetera. And you could actually really see nicely how that was compressed and C2 had kind of drifted back. And we put pressure on C2 and we could see that then there was CSF flowing around there and the cord became pulsatile again. So I had somebody hold it in that position and quickly put in occipital screws and some C2 fixation, and the signals returned and the patient woke up with no deficits. And I would say at least 2 or 3 times a year that being able to look at it real time with the intraop ultrasound has been very helpful to me. The other thing that I have learned definitely is that cords don't like being stretched. And so sometimes when I'm doing like bigger resections, I kind of try to think about doing it stepwise so that you can create a little bit of compression and kind of take the tension off. And this was a kid that had grown up in China before being adopted in the US and had a history of TB. And I had 2 rods for stabilization, but still, even before doing anything to the posterior wall, had just a little bit of drift and lost MEPs. And we basically kind of had taken this stepwise approach of trying to get this middle apex out first, and then we're able to compress, and the signals went back to baseline, and we were able to complete the resection and actually get quite a significant amount of compression or correction. I've also developed a much lower threshold for staging. If there is a significant loss of signals, and especially if you get them back to baseline, you may just want to quit while you're ahead. And this was a series that we did prospectively, and of the patients that had 2 neuromonitoring changes, it was 2 to 3 times longer for them to come back than the initial episode. So that's kind of the math I think about. Like if it was, 3 minutes and you got them back, then probably not a lot to risk. If it was 30 minutes before you got it back, probably think about hanging it up for the day if you can. And then there's a lot of debate about this, and I'd be curious to hear what other people do. Our kind of protocol has been MAPS as high as is needed to have the signals present, as long as they wake up okay with no deficits. And then if there's weakness or the MEPs have stayed out, then MAPS above 85 for 5 days. So we start out looking like this in this line of work, and these cases age us, but there is a lot of learning with them, and I hopefully that will spur some good discussion. So thank you.